I would love to learn just more about your background as a psychiatrist and what brought you to Compass. So maybe we could start there before we dive into the actual questions.
I initially started out as a chemist. When I was in college, I loved math and chemistry. So after graduating, I worked as a chemist for a short bit. But while I was there, I didn't have any of the in-person interactions that I was looking for. We sat around the lunchroom and no one really talked. It was very isolative. And I was complaining to one of my friends who went into med school, and he said, "Hey, if you love science and you love people, medicine's the way to go." So open-handedly, I pursued med school and was able to get in. When I went in, I wanted to be a surgeon or a emergency room doctor. And it wasn't
Okay.
until I did my psychiatry rotation, because it was something I'd never been exposed to, that I saw how much time providers got to spend with their patients and how much lives changed as a result of just treating them and kind of going through life. So that totally pivoted my perspective. And then I did my residency at Cleveland Clinic out in Cleveland. And when I was there, I had minimal experience with PHP or IOP. It's just something that we didn't do. We didn't have a strong PHP IOP presence, a lot of consults in academic medicine. And applying for jobs back here, I found Compass just randomly as I looked into it more and more. And then when I interviewed, hearing about the free flow nature of caring for patients, the immersive aspect of having an individual therapist, a family therapist, and groups happening, I thought, I really love collaboration. And I believe that in order to really make a difference, it takes a village. It takes many people with different expertise coming together. So that's what led me to coming here. And I've loved it. I genuinely love my job. My wife laughs because on Sunday night, she'll notice I start to get a little bit excited. She's like, "Hey, work doesn't start till tomorrow, so it's okay."
Oh, that's funny. Oh, that's amazing that you love it so much. It sounds like you landed in the perfect specialty for you. How long have you been with Compass?
I'm coming up on 4 years in August, I believe. 4 years in
Okay.
August, yeah, 2026.
Amazing. And what location are you based out of?
So I've always been Northbrook since coming here, and then I'm an over 18 psychiatrist. But a
Okay.
year ago, I took on the role of associate medical director, so helping out with the under 18 side in different ways.
When people think about mental health treatment, they often picture weekly therapy or occasional psychiatry visits, maybe a monthly kind of check
Mhm.
in with their psychiatrist. How do you define outpatient care and anything where you're not staying overnight somewhere?
Outpatient care is a broad umbrella term that encompasses many different facets. At its core, you just don't stay overnight. If you can leave at the end of the visit, it would be outpatient care. Within outpatient care, you have your traditional outpatient visits, which is what we think about. We're meeting with a doctor or a therapist for 30 minutes or an hour, once a week, once every other week, or every few months. But then there's also more immersive forms of outpatient care where you're there for a prolonged amount of time, like IOP or PHP. But at the end of the day, you're still able to return home, take care of responsibilities, potentially even work. It's a way to just integrate mental health treatment into your daily life.
Where do intensive outpatient programs and partial hospitalization programs really fit within that broader continuum of mental health care? Can you tell me a little bit about that?
IOP PHPs are the middle ground. They're the in between a more lenient or flexible outpatient care and then more immersive inpatient care, in the sense that patients with an IOP or PHP are there for a prolonged amount of time. It's usually patients who are struggling to a deeper degree. And it's also designed to keep them from having to go to the most restricted level of care, which would be the inpatient units or even residential care. Patients tend to need a little bit higher level of accountability, higher level of monitoring, a little bit more immersive treatment. But the purpose of it is still to design to keep you while living your regular everyday life.
What are some kind of signals that that person or their caregiver could take into account? Oh, maybe the PHP IOP level of care is what might be right for me. What are some signals?
One of the things I tell my patients is, how do you know whether a tree is good? And you check the fruit. I've had a lot of patients who have done outpatient care, seeing their therapist weekly, adjusting medications for a long time. And a lot of times we just take our day to day with the problems that are given in front of us without zooming out. And with patients, when you finally step back and say, how am I doing over the past year or 5 years? Am I making progress in this? Sometimes the answer is no. I'm still struggling with social anxiety. I'm still having a hard time getting my act together and keeping a job. I'm still really having this depression that hasn't been resolved. And even though I've given outpatient care, given outpatient therapy, outpatient psychiatry a good shot, there's still these issues. In that regard, if you're still struggling, it's time to just crank up the intervention, just nudge it up a little bit to do something a bit more immersive with the thought that the current level of intervention isn't adequate for it.
And I think a lot of people immediately think, well, if I'm really struggling and day-to-day life is really hard, I'm seeing my teen and they're not able to really function anymore, they immediately think, I think I need to take them to the ER or I need to take them to the hospital. Can you speak a little bit to that and maybe when they could actually call somewhere like Compass or PHP IOP instead of just automatically going to the
Mhm.
hospital?
Yeah, we always think about the emergency room as that saving grace. It's drilled in with every TV show and movie that's out there when somebody's sick or they've fallen or a heart attack, right to the ER. We have the same thought with mental health, and it's not the most accurate thing because the ER isn't designed for treatment. They're designed for stabilization. In fact, most people who have been to the ER realize there's long wait times that are there. And especially from a mental health standpoint, unless there's an acute safety concern, they aren't going to provide any sort of treatment. Mental health is a long-term work to try and improve someone's
Ooh.
mind, improve their life, where the ER is trying to keep their metrics as small as possible. 10-hour visits, 12 hours visits if possible. So instead of thinking it in terms of the ER, you need to be able to talk with somebody who can guide you about what you need. If you have an outpatient therapist, or if you have a psychiatrist that you can reach out to, or even Compass, we've done a good job doing interventions to get care to patients faster, trying to get them in, knowing that that gap between when they need help to the time when they are able to receive help is such a vulnerable state. So even reaching out to a place like us and saying, do you think that I'd be a good fit? We'd be able to give advice. And if it is, get you in as soon as possible. The worst thing that someone can do is not just struggle, but struggle alone and struggle for a prolonged amount of time.
That's such a good point, being able to really just get that support as quickly as possible. And I know at our different locations, we're often able to get folks in within 24,
Mhm.
48 hours, just within a day or two. So I'm so glad that you brought that up. Maybe we could dig in now really into the differences between IOP and PHP. I think that those terms can sound a little bit scary to folks sometimes. They sound really, partial hospitalization program, intensive outpatient. It can seem a little daunting. So I'm hoping you can kind of bring them down to earth a little bit for us.
Yeah, acronyms are always scary when we don't exactly know what they are. And even what these acronyms represent, they're historical terms: intensive outpatient program, partial hospitalization program. There are some intimidating aspects about that. Instead, what those two terms differentiate is the two tracks of how we treat patients. PHP, partial hospitalization program, is our most immersive way that we manage patients. They're here for a longer amount of time. It's designed to help patients stabilize. They're going to see their team more frequently. They're going to receive a couple extra groups and a little bit more one-on-one time while they're in program. It's very useful for people who are just coming in, who are trying to get started and just even understanding what all the problems are that they're dealing with and how they can get their feedback underneath them. Then IOP, intensive outpatient programming, is our less restricted, it's our less immersive form of treatment. They're here for just the morning portion from 9:30 to 12:30. They're still checking in with their team, having one-on-one sessions with their psychiatrist, their family therapist, with their individual therapist. But there's a lot more time spent in group, and they have a lot more hours of the day left to their own devices. If they want to volunteer or start working out or resume work in some situations, manage home responsibilities. It almost provides that kind of reintegration back into their everyday life. And they can use the morning part of program as a form of accountability to say, how are we doing? How did the previous day go? How are we working on our goals? How are you also managing it as you're kind of gradually transitioning out of program?
Okay. I'm glad you touched on the different facets of care for both. Let's dig into group-based care a little bit more. If someone's unfamiliar with that style of therapy, group therapy, being in a group with others, or maybe a parent is a little bit hesitant to have their child or teen in a group setting, can you speak to that and why it's such an important part of IOP and PHP programming?
Yeah. At our core, we are a groups-based program. That is the bulk of what we do. The good work that we do, a lot of times it has its true foundation in what happens in those group rooms. Individuals who are struggling are with other individuals who are struggling, and that breeds so many positive aspects. There's a shared commonality, kind of this idea that we are all human, we're all going through it together. It's one thing to struggle, but mental illness in and of itself is very isolative. Whatever it is, anxiety, depression, psychosis, substance use, it makes you pull within yourself. You feel misunderstood. There's a lot of guilt and shame in just walking into a room knowing that there's 6 other people, 8 other people, 20 other people who are dealing with the same thing. Just takes a bit of the weight off of your shoulders to say, okay, I'm not alone. I'm not the one who is going to be misunderstood by everybody. So there's the common humanity part of that. But then there's also the difference between what I would say is mental health knowledge and experiential wisdom, where any sort of therapist or psychiatrist can teach you all that we know from working with patients, from the studies that we read, from our residency and trainings. But there's also a different form of impact that comes from a patient who has experiential knowledge. If one person struggles with panic attacks, hearing somebody else who's also struggled with panic attacks describe what's worked for them, how they saw it, how they were able to learn coping skills, that experience of coming from a non-professional, but somebody in the same boat carries a lot of weight.
Yeah, just to see yourself in someone else's shoes, even if your experiences aren't exactly the same, that can feel so comforting. What about for parents that are a little bit worried about that, for their child or teen? Like, I understand the common humanity part of it, and I understand being able to relate to one another, but what if they still have a little bit of hesitation? Especially for parents, I don't want my child to be exposed to others that are struggling.
Mhm.
Could that impact them negatively? I'm sure we get those questions. How do we respond to those worries?
Yeah, I think it's a misconception that by putting people who are going through something similar in a room, they'll actually bring each other down rather than build each other up. And I think it loses sight of the main premise that we are a voluntary program. Everyone who walks in our door is trying to get better. They're taking time
Mm.
away from their life, their family, their job, these things that they are building up for their own future in order to really try and work on their mental health. The model of using people who are struggling to kind of help others, we see it as one of the anchor points of AA, which is one of our best
Mm.
kind of approaches to treating sobriety. We also see it in school. You're trying to put a bunch of peers together in a same room, trying to cover the same exact material, hoping that with that collaboration, they'll all be smarter as a result of it. There's something about community that especially in this modern world where we're lacking it in so many ways, and to have community of individuals who will get you and experience this slice of your life, the mental health part, not just with the struggles that you're dealing with, but how you're learning and growing. A big part of being here is almost what I would call a tiered system of patients. You have the person who comes in for their first or second day who's brand new and everything seems overwhelming, but they're also sitting next to somebody who's been going through the program for a bit. They're starting to make changes and they're experiencing the difficulties of trying to live a new life and to have a new mindset towards it. They're also alongside people who are getting to the end of their time at Compass, who have overcome, who have achieved. And all three of those people are able to talk together and kind of work through taking on the new ownership of impacting patients, being part of the solution. It's this ever revolving wheel where everyone fills a role that's well needed.
That must feel so comforting to a degree as well. Like, wow, maybe on my first day, I feel so overwhelmed and nervous, but I can see someone who's nearing the end of their
Mhm.
treatment and wow, like they seem like they're doing really well, like that could be me. So I'm
Yeah.
so glad you said that. That's really inspiring. Let's talk a little bit about psychiatry and how psychiatry really fits into our treatment model as well. I know all of our programs are psychiatrist led,
Mhm.
part of our treatment teams. All patients go through a psychiatric evaluation once they start program and then have regular check-ins. Can you dig into how psychiatric care fits into all of our programming and how it supports just all of the treatment modalities while someone's in program?
With PHP and IOP, we view it to be three legs of a stool, the three legs that support the weight of getting the patient better. One of the legs is group therapy, learning the skills, kind of being exposed to material that way, almost sort of like a classroom setting. Another leg is the individual therapy, which comes from an individual therapist and a family therapist meeting together in that form, working on integrating skills on a more one-on-one basis. And then the last leg is psychiatry. In psychiatry, I think people pigeonhole it into just medication management, which is very important. It is a bulk of what we do. But also with psychiatry, it's the diagnosis, trying to really figure out what is going on. Usually when people are coming in here, they've been diagnosed with something and they've been treated for something, but the reason they need PHP IOP is because they're still struggling. And a lot of times the diagnosis needs to be refined. There's something else that needs to be added in, or something else may be misconstrued or misunderstood. And that's why treatments haven't been effective. Then also working with psychiatry outside of medication management, we're all trained in our own forms of psychotherapy. Compass's PHP IOP are heavily involved with DBT, ACT, and CBT, where a lot of psychiatry, as much as you're immersed in those schools of therapy, there's also other forms. And to kind of round it out, to say, all right, this isn't going to be the bulk of what you do, but here's something else to consider. We are really well versed in substance use, well versed in brain pathology, well versed in how to integrate and build up healthy habits, and be able to use data, being able to use the studies that we have. So it's something that I found to really cherish, where almost for a lot of my patients, the meds are just a small part of what we do in our visits. A lot of it's also accountability, trying to build up these things that we know are healthy for them: physical exercise, diet, hobbies, friendship, a passion, some sort of life purpose. Those are the things that can happen with those one-on-one visits.
And how do the psychiatrists work within the treatment teams? I know, there's such a team-based approach to our patients' care, and that throughout their time at Compass, treatment plans are adjusted. There's conversations going on a daily basis
Mhm.
amongst the treatment team so that everyone can support the patient to the best possible way that they can. Could you speak a little bit to that?
The peek behind the curtain is that there's a remarkably high amount of collaboration. We are always talking, whether it's as a group or as individuals, the psychiatrist, the family therapist, individual therapist, and the group therapist. Knowing that everyone has a different perspective of what they're seeing, we also are always trying to chip away at different degrees about what we can solve for the patient and who's best equipped for it. With having multiple people on a treatment team, you're going to have slightly different relationships. The North Star is the same for all of us, for what we're shooting for a patient to be able to function in the life that they have. And yet we all get to use our own specific training, skill sets, personality, relationship, and background to chip away at these problems. In certain ways, it's more comfortable for me to have the conversation about patient substance use, whereas the family therapist is really going to focus on their dynamic with their father, getting that restored. The individual therapist may be talking more about group overall and building up hobbies on the outside. And we're hearing how they're doing from the group therapist and how they're integrating with everybody else. It's sometimes we're all unified and working on the exact same problem. Sometimes we're allocating what we're doing, but it's always this multi-headed approach to try and figure out how best to get the patient where they want to be, how best we can get them to achieve their goals.
And how does that differ from outpatient therapy or outpatient psychiatry? If someone is, going for weekly visits or monthly visits, how does that model really change?
Modern mental health care is very siloed, where an outpatient psychiatrist sees the patient and typically it's just pure med management. And then an outpatient therapist will work to see the patient, but a lot of times the communication is difficult between. People are overbooked. There isn't provided time for communicating, getting in touch with other individuals. So, a lot of times when you're treating a patient, you end up on an island, which is difficult because there's certain problems that need the part of treatment that you aren't able to access. As a
True.
therapist who is not aware of what's happening with medication, it's hard to know if the meds are actually being optimized or what you should expect from that. As a psychiatrist who may not have more than once a month visits or once every 3 month visits, it's hard to really dig into their hobbies, their social connections, how fulfilled they are feeling at work. So it's the lack of communication is a tough thing, and it actually provides a barrier to patients getting better.
And so Maybe we could go in a little bit deeper to that in terms of just medication management specifically. You said, maybe
Yeah.
you're seeing an outpatient psychiatrist monthly or every 3 months and you're getting that medication management. How does that differ when you're in a PHP or IOP level of care, specifically for medication management? How does
Mhm.
that look?
I believe that PHP and IOP care is best suited for medication management. In mental health, we rarely have quick fixes. Our meds take time to settle in. Our antidepressants,
Mm.
our anti anxiety medications, our time course that we're looking at is weeks instead of days. And in that sense, being able to start a medication and then follow up with a patient multiple times for a week, you have the ability to check for side effects early on. You also have the patience of knowing you're going to see this patient for a couple weeks to see how they're responding to treatment. Outpatient care, especially with providers being as busy as they are, it's hard to get in when you have a medication side effect. It's hard to get in to really abruptly manage things or pivot and change in a big way or cross saber between medications. Whereas on the other hand, the most immersive form of care, the inpatient unit, that is where they can monitor you 24 hours a day, but their admissions are so short. 3 to 10
Mm.
days, knowing that most of the meds that they're starting won't even have their effect until a couple weeks after you discharge. Taking the time with IOP PHP, it is this nice privilege of really being able to walk through medication changes, adjust things to a small degree or a high degree, while patients know that I'm always 45 feet away. And if anything comes up, they can have access to me.
And so you're able to really get them started on medication, adjust those
Mhm.
medications, reevaluate what's working, what's not working. And this is all kind of done in real time, it sounds like.
Absolutely.
Yeah.
It's a fresh set of eyes as well. I think a lot of times people think about the idea of adding on more meds or getting on the right meds. About 50% of my patients, the first half of their time at Compass is actually coming down on meds. Little by little,
Mm.
things have been added on. All of a sudden, you're taking 7 or 8 medications. And as you ask, what are we using these for? People don't know. How meds were described to me was imagine that you are the CEO walking through your brain. And if you looked at any med and said, what's your job here? If a medication said, I help with depression or I improve motivation, you'd keep them on. Whereas if you looked at a med and said, what are you doing? Why am I taking this? And you have no idea, no CEO would let that person continue to work at their job. So a big part
Right.
of what we do is figuring out that right balance. And that right balance isn't just from a med to med standpoint, but even saying, how much of what we're dealing with is a medication problem? It seems strange, but a lot of times we assume that meds can solve more than what they can. When I have patients come in
Mm.
for the first time, I'll say, all right, what are the problems that we're dealing with? What are we trying to work on? And then I'll get a long list. My anxiety has been a little bit higher than what I want. I have panic attacks every now and then. My job just isn't fulfilling. I always wanted to have a career that I really look forward to, and my family relationships aren't good. Once we get a little bit of the lay of the land, I'll ask them and say, all right, which of these problems are we going to try and medicate? It seems like a goofy question, but sometimes we just assume that if my meds were good, I would love my job a whole lot more. When in actuality, no matter what dose of Prozac you take, your boss will always remain your boss and function in the way that they are. No medication can restore family relationships. No medication can make us not be a picky eater. But instead, there are things that medications can do for us. And then to use that as part while also using the other resources of Compass, individual therapy, coping skills, lifestyle changes to really round out when people do a treatment like this, because they're focusing so much on, yes, the neurochemical, but also on the psychological part, they actually end up taking less medications because they're able to support their own mental health.
Wow, that's so interesting to think that someone can come into Compass taking too many medications and you can actually adjust and refine and really figure out what is necessary and what's going to help them thrive. And that's actually less than what they came in with. How about for folks or parents who have never taken medication and they're a little bit hesitant that, okay, if I start a PHP IOP, there's psychiatrists, there's medication management, I'm going to have to do that. And we know that's not the case. It's not automatically you're going to have to be prescribed medication if you're in a PHP IOP, but sometimes there's that fear, right? Could you speak to that, please?
Some of my favorite patients are the ones who actually want to avoid medication at all costs. A lot of different reasons behind it. Either they've got medical problems and are on other medications for parts of their body and they don't want to add more things in to complicate it. There's skepticism towards psychiatry or pharmaceutical companies, or just even skepticism towards the mental health field. I really love working with patients who do not want to be on medication because you get to partner with them and you know that they're going to be motivated to then solve their problems in other ways. I think there's maybe an over reliance on medication in certain ways. So instead, when I have a patient comes in and says, I don't want to be on medication, I'm a little bit skeptical of this, or I'm strongly averse to it, what I'll say is, all right, what do you believe in? And let's lean into that. If it's going to be religion, if it's going to be exercise, if it's going to be hobbies or socialization, if it's going to be coping skills, I'll say, all right, let's start with the things that are most aligned with your values, your ethics, and your goals. And I am going to serve as accountability and support and your biggest cheerleader through all of that. For you and I, let's keep medications as option K. And we're going to start working through options A, B, C, D, and E. What I've found is that a lot of times, either one, the patient's correct and they didn't need medication from the start, which is all the better. Or two, they're going to start making improvements, going to sleep earlier, improving their diet, trying to be more diligent with using coping skills. But they'll notice there's still something left on the table. There's still something that no matter how much they've changed themselves, they still can't quite quell down the anxiety or their mood or their trauma symptoms like they would want. And at that point, because I've partnered with them and because they've been able to enact the changes that they've wanted and nothing was forced, people arrive at the idea of medication with much greater unity, saying, okay, I've done it. I do think something more is needed. Now we've arrived at plan K. Let's give medications a shot. The nice thing about it is, one, it keeps that doctor-patient relationship strong. Also, you know that you're medicating a small part of the problem because everything else has been optimized.
Sounds like you have a really holistic approach to patient care, which is so great to hear. And I think such a highlight of the PHP IOP model because psychiatrists are really able to accomplish that within that setting, which is really, really cool.
With each patient, it's always interesting who's the most important part of the team. The team is phenomenal, and I do love each part of it. I love getting the A part of it, though, is that some patients, family therapy is what carries the bulk of their treatment. And I am convinced that that was 50% of the reason. Rectifying those family relationships, resolving their marital conflict, and pushing them from divorce to reunification. Sometimes it's their relationship with the individual therapist. Sometimes it is just being in group, learning the skills, forming a community for people who've been isolating for a long time and they finally realize what that's like. Sometimes it is medication. There are so many ways to skin a cat in mental health. And why I love working here is we can always start with what the patient values most. Nothing is required. Nothing is forced. And instead getting to partner with them because we are a temporary program. And what I want is that by the time they've completed our program, they know their own values. They know what they need to do. And that's the knowledge that will keep them not just healthy for while they're in Compass, but for the decades after they leave our program.
And you made such a great point that really at the core of our PHP IOP programs is that individualized, personalized approach, right? It's not one size fits all. It's like you said at the beginning when you speak to a patient, what are your values? What are your goals? What are you looking to accomplish here? It's not, okay, this is the prescribed course of treatment and you're just going to follow it. So I think that will feel really comforting for people to hear. I would like to get into also a difference between outpatient therapy or psychiatry versus PHP IOP is our ability to really treat at a high level co-occurring disorders. So if someone is struggling with trauma symptoms as well as mental health and substance use, we can do that concurrently at the same time in our programs, or struggling with OCD and trauma or whatever they are struggling with. We're able to do that all under one roof concurrently. Can you speak to how that impacts a patient's treatment outcomes and their trajectory in general?
When people first come into Compass with my first meeting, a lot of times at the start of the conversation, you say, hey, tell me what brought you in here and what can I do for you today? They'll usually list off 2 or 3 things. I know from the get-go that the 2 or 3 things are what's on the forefront of their mind, but give it enough time, that laundry list will continue to grow. And it's not even not the most important thing, but at some point you have on there these smaller problems that come up. Sometimes they're medium-sized problems. Sometimes they're subtle, larger problems that the patient didn't even know they were struggling with. By having PHP and IOP, you are immersively in a patient's life. So you get to see all that they're dealing with, their strengths and their weaknesses. People can't get better until they can resolve a lot of these things. There are these hangups where your mood could be better, but if you don't have something to do with your better mood, it's not a better life. Our North Star
Mm.
is the functionality. Can you live your life and enjoy your todays while also appreciating your yesterdays and looking forward to your tomorrows? So with that, Compass has realized we need to be broad in our approach. One of the misconceptions about Compass is that we just do depression and anxiety, or you need to have a certain level of severity for the symptoms that you're dealing with, when in actuality, the problems that keep us from enjoying our life are way more immersive. Sometimes it is treating those mood symptoms, but also trying to reconcile the trauma that you experienced or those parts of your childhood that you never were able to open up and really put to rest. Accountability for substances, accountability for enacting other changes. You see somebody every single day while you're here. So it's really easy to say, all right, between now and when I see you at 9:30 tomorrow morning, what are you going to do that's going to be aligned with your values, and how can we support you with that? And know that tomorrow I'm going to ask about it. So you got that little bit of pressure to follow through on what we're talking about. Compass has created different programs that patients can utilize to best serve them, whether it's our trauma program, our substance use track, our chronic pain program, our OCD program, and patients oscillate between them. It's very common to have a patient who comes in who says, trauma is the main thing that I need, and they start in that program. But as their trauma symptoms reduce, it becomes more prevalent that I didn't realize that I was using marijuana as more of a crutch than what I wanted, and I'm having a hard time walking it down. I'm going to switch from trauma now over to our substance use track. We are an open playground for you. Use us as much as you can, knowing that the team and the patient both have, as you get to know each other, have a better idea of what the person needs for their next step in treatment.
Thank you so much for going over the differences of the different programs and how they can work together. I think that's such a differentiator for folks that are seeking the PHP IOP level of care, that we really do truly specialize in those areas and can treat them concurrently. You don't have to go to different locations. You can just be under one roof, and we take the complication out of it. So, I think there's, unfortunately, still in our mental health landscape today, there's still a lot of shame that comes with asking for help. And, more so at the PHP IOP level of care, I think reaching out to an outpatient therapist has been thankfully more normalized over the years, but there still is some shame associated with it, right? So how would you respond to someone who feels like they really should be able to manage their symptoms or manage their life with weekly therapy alone? They're struggling to come to terms with the fact that they might need more support. They maybe feel like they're a failure. How would you speak to them?
Yeah. A thing I'd encourage anyone who's struggling is to be honest with yourself. Take a moment and just take a look at your life and say, where am I satisfied? Where am I having some difficulty? And be broad. Let it be with your understanding of yourself, your self-worth, your body image, your understanding of your strengths and weaknesses. And if you feel like you've really achieved the potential that you need, your relationships, your friendships, your role, your vocation, your career, how you're impacting the world around you. Be honest with yourself and see, okay, what's going well and what's not going well, and drop a pin to say, all right, this day at this time, this is how my life is going. And then try and make a change. If through outpatient therapy, if through intentional effort, you're able to make progress, a program may not be needed. But for the majority of individuals, they never bother to do that larger overview to realize that they are dealing with the same problem year after year after year. The mask that it's wearing might look a little bit different, but still some of these tendencies, they're the exact same. And it's been a hard thing to make progress. And in that sense, PHP and IOP, in my mind, it's the thought of you're going to lose some time to gain some time. It can seem immersive to come in for 6 weeks, 8 weeks, 12 weeks. But I promise with the patients that we work with, those 12 weeks stop years or decades of continued struggle. And the functionality that patients have when they leave our program, it allows them to derive so much more fulfillment and success in what they then turn their hands towards. And it's multimodal. one of these things where you're not investing in just a very specific problem of just my mental health. When you leave program, I want my patients to be better fathers, better mothers, better employees, better friends, better neighbors, just better lovers of themselves. It's these things that it sets seeds that produce a great harvest in so many paradigms of life.
Thank you so much for saying that. That was such a wonderful way of saying what progress can look like when someone is in the right level of care for their needs to become a greater lover of themselves. I love that. What does progress tend to look like when someone's in the right level of care? How quickly can that happen? What does that look like?
Progress is never linear. It would be easier if it was. But if you're at the right level of care, things will start to change. Things will start to change in the sense that you'll see tangible benefits of it. All of a sudden, someone is going to bed at an earlier point. They're doing a better job of maintaining their daily responsibilities. They reached out to a friend that they had been thinking about for a long time. Sometimes the tangible benefits aren't as clear, but you'll get the intangible. I just feel better. I woke up in the morning and I just didn't have that cloud hanging over me. Or my movements throughout the day. I don't have to give myself as much of a pep talk to get out the door. Instead, the barriers that were kind of present in my own mind just seem to be shrinking down. It doesn't take long. If it's the right treatment with the right intentionality at the right time, a matter of days or weeks will start to prove that this was the right answer. A lot of treatment at Compass, in my mind, what I tell my patients is it's a momentum game. The first change is always the hardest. That's the hardest one, coming in and then figuring out what's that first thing that we can do differently. But once someone makes that change, they feel the benefit of it. So they're a little bit more willing to do that second change. All of a sudden, a couple weeks go by and they've made 10, 12 changes and they feel all the positivity about it. They're almost coming in to say, Dr. Klint, here's the next thing that I think we need to focus on. What would you say? Here's my plan for how I want to enact the change. Do you think this is a good plan or not? It's a momentum game and it's that first step. So for patients, one of the hardest things they're going to have to do is just walk in the door. That's what I would encourage anyone with. That's the biggest, toughest step. Once you're here, you're going to have a whole support system around you, and we will slowly start building up those changes together.
Well, thank you so much, Dr. Klint. That was really fabulous. I think you touched on so many important facets of our care at Compass and just PHP and IOP in general, mental health in general. So thank you so much. Is there anything that I didn't ask that you wanted to touch on?
Nothing else. This was really, really great. Just one other thing I would say is for individuals who are curious, just reach out to us. Just give us a call. It's low stakes or anything. More information just helps. Just kind of figuring out who we are, what we're about, what our patients experience. The unknown is one of the scariest things, but a lot of times it's a shadow on the wall where it doesn't carry the weight. It isn't actually something that's as bad as what we chalk it up to. Be willing to do something different. It's a tough thing being in the world today, and there are resources that are designed to help.
That's such an important point that even if they're unsure what might be best for them, that just reaching out, whether it's to us or to a school counselor or to
Mhm.
an outpatient therapist, just to reach out and start that conversation can make
Mhm.
the wheels start turning. So thank you. This was a great conversation. Thank you so much, Dr. Klin. It was really lovely to speak with you this morning. I appreciate your time.